Yes, yes. I will be quick, like 10 minutes most, because I don't want to discuss the entire prophylactic antibiotic gamut, because it is hardly relevant for to know all the guidelines, all the antibiotic prophylaxis which are recommended, which are not recommended. Basically, we want which field we are practicing. Either we are surgeons or we are like endoscopist doing endovascular procedure, endoluminal procedure, or we are physicians. So basically, you keep in mind what you are and try to imbibe what is relevant to you. So coming to prophylaxis, everyone knows it. What is prophylaxis? So it is basically, it may be a primary thing, it may be a secondary prophylaxis, it may be a eradication. The purpose, basically, why we want to give a prophylaxis, whether we want to eradicate the organism, whether it is a primary prophylaxis because uh, we suspect this patient will get this infection, or it is a secondary prophylaxis, patient has already got the infection, we don't want a recurrence, or a chemoprophylaxis, like it can be a preventive of disease or infection which has repeated times or recurrences occurring. All it may be a policy decision by the government or a particular clinical scenario like an epidemic, like we have seen in COVID. We have taken all sorts of prophylaxis for then. Otherwise, if we live in an endemic area, we will also, the government guidelines may tell us that we will use that antibiotic prophylaxis in that particular area. So it can be in different stages. So what's the harm? Harm we have, this is all antimicrobial stewardship or multi-drug resistance. So obviously we are aware of that if we overuse these antibiotics for like our it kind of prophylaxis thing, then we may land up in antibiotic resistance. All drugs come with some side effects. It may be allergic, it may be organ dysfunction kind of thing, or this organ dysfunction can be anything, neurotoxicity, hepatotoxicity, nephrotoxicity, or obviously cost of antibiotics. Then benefit, we suspect that if we use that prophylactically, if we are able to demonstrate that it is beneficial using this drug prophylactically, then patient may have less morbidity, mortality, duration of hospitalization can be shortened, or it will finally lead to decreased healthcare costs. So indications, as I told you, that it may be a surgical thing, it may be a non-surgical procedure, non-surgical procedure, it can be medical. So surgical people's, the guidelines are very clear that in few patients and few surgical things, the evidence is quite good. It is kind of level 1 evidence, or for some surgeries, not all surgeries. So what is the basic principle is that the bacteria which we should use the antibiotics, which bacteria to target. This is either a GI flora or a skin flora, because most of the surgery is done through the skin. First thing is you put in skin incision, or any intra-abdominal operation, the GI flora may translocate either from the patient or the operating team. We also carry some, we may also carry some unusual flora, or we may have staphylococcal carriage, the operator may itself, or our environment, the operating table may, operating room may harboring some organisms. So it's mostly, it should cover that. It's not necessary that you should take care of each and every organism in your prophylaxis regimen, but you should keep in this mind. And the type of surgery, whether it is clean but may be contaminated, clean surgery with an artificial processes or artificial inanimate object which you are putting inside, or the consequences will be devastating to the patients. Like you cannot take chance in neurosurgery or cardiothoracic surgery or ophthalmic surgery. Other surgeries you may be little considerate. So, and lastly, we should see whether the patient has Staph aureus nasal carriage, and this is, so this is very clear in surgical field. It is very clear that we should use. There is no question. Next comes non-surgical procedures. So non-surgical procedures, endoluminal or endovascular procedures, or very small biopsy or abscess drainage, as minor procedures, whether we should use or not. So the guidelines is like plus minus. Only the definite evidence has come from prevention of infective endocarditis, whether it is subacute or acute. So dental procedures are not considered as surgical procedures. So this leads to a transient bacteremic phase, and if there are certain high cardiac risks or immunocompromised, then you will require, otherwise you will not require. And medical thing, so medical people are always confused. So some guidelines says it should be used in some conditions, some guidelines says that now evidence comes and evidence goes. So it is very fast changing in which conditions, in which medical conditions use prophylaxis, what is the evidence, what is the duration, what is the dose, no one actually knows. So coming to the most definitive part for surgeons mostly. So basically these are essential component of your surgery, there is no doubt, and always risks and benefit you have to see. Antibiotic only selected circumstances, not all surgery requires a antibiotic prophylaxis, and always you should, the risk benefit should consider whether you are going to potentially select an organism which is multi-drug resistance. And most important thing is timing. Your timing of antibiotic prophylaxis should match your operation plan. So usually the guidelines is you should be in 15 to 60 minutes before your skin incision. You should be giving this drug so that your MIC is, when you are actually operating, your skin in the body has above MIC, the concentration of drug is above MIC. So this timing is very important than selecting a drug. That is very important. If you miss this timing, then you have to give another prophylactic dose. So clean procedures rarely require unless it is a high risk procedure. If you are using an prosthetic material, clean procedures, there are no acute inflammation or transaction of GI, oropharyngeal, the areas which are normally colonized by bacteria. If you are not transecting that area, you will not require. So the activity of prophylactic agents should encompass most common. You should not cover the entire organisms. So it's said to be narrow spectrum, so that you are not predisposing to development of multi-drug resistance. And you can use some local susceptibility data. Most of the guidelines will not tell you that which drug specifically to give. So ultimately, there is a footnote that you should use your local susceptibility data of the antimicrobial incidence of antimicrobials and what drug they are sensitive. So as I told that this antimicrobial infusion has to begin 15 to 60 minutes before your incision, with some exceptions that you can go specifics, you can go. Weight-based dosing is always recommended because of overdosing and organ toxicity, because you are using it as a prophylaxis, not as a treatment. So you should be using the amount of drug which is actually required for the patient, not more than that or not less than that. So this is weight-based. Is redosing is sometimes required if you are prolonging the surgery or there is a lot of blood loss or fluid loss, then you may replace this dose of prophylactic antibiotic. So mostly these are discontinued after after intraoperative period. Some rare cases you may continue the same drug, or if the patient is even getting an systemic antibiotics before the procedure, then that antibiotic has to be continued. Even if the patient is getting an antibiotic before the procedure and you happen to use the same antibiotic as a prophylactic agent, or your guidelines tell that no, you should use a prophylactic antibiotic, you should give an extra dose, because the timing is important. You may have given the antibiotic dose 2 hours before, so that does not help for the purpose of prophylaxis. So you have to give the same dose within 60 minutes of your skin incision. That is an important thing. So next, coming to procedural. So we don't consider many procedures we don't consider as surgery, like endoluminal procedures or endovascular procedures or dental procedures, or some skin biopsy and muscle drainage of abscess. So basically the premise is that the patient should not get infected. There are high in 1980s actually many patients died of infective endocarditis. After that, in 1999 and 2008, two guidelines came from AHA. they recommended few indications of cardiac patients who will undergo some kind of dental procedure or skin procedures. They should be given an antibiotic prophylaxis. So the guideline is recently updated in 2018. So there are very few indications because we have to target Streptococcus viridans and Staphylococcus aureus. So if the patient has prosthetic valves, if the patient has previous infective endocarditis, cardiac transplant patient, or congenital heart disease, if they are uncorrected, and if they are corrected with a prosthetic valve kind of thing. So cardiologists must be knowing this, and they should know it. So what procedures will, not all procedures will require. There are dental procedures, not all dental procedures again require this prophylactic antibiotics. Few dental procedures do not require also. Invasive respiratory procedures like bronchoscopy, if you, even only bronchoscopy does not require, bronchoscopy with biopsy will require. So there are definite AHA guidelines on that, you should know. And infected, if you are doing a procedure on infected skin structure or musculoskeletal cells, so definitely what antibiotics you have to use, their guidelines is also there. So medical conditions, as I told, if I want to discuss each and every medical conditions, because it will take another 3 hours. So they are the most confused peoples when to use, what to use, but there is a consensus kind of thing. There is no single guideline which states which encompasses all the kind of all the diseases or clinical condition. But you have to remember the field you are working, the department you are working, and the patients you are dealing. Side hematology people should know what prophylaxis should be given to a stem cell population. Kidney transplant people should know what they have to give. Patients who are seeing, who are doing, who are seeing children's, they should be knowing when to prophylaxis, what exposure the patient needs and prophylaxis. The patient in MRS department should know which when to treat, when to give a prophylaxis. So there are definite conditions, there are definite guidelines, consensus guidelines. So we'll not go into details. And finally, you have to remember, because we are using this drug not as a part of treatment, but as a part of prophylaxis, our fancy that this patient will get this infection, so that I will prevent this infection by giving this antibiotic. You have to always weigh this thing with drug intolerance, organ toxicities, and you should always consider alternative regimens. If the drug, they are allergic to some kind of drug, then you should be knowing what are the alternative regimens which are recommended or which are being practiced. I will not go into details. We have a long list. There is a very good site in University of Michigan site. I have most of the things there. They are now updated up to March 2023. Most of the guidelines they have analyzed, and they have kind of stabilized this thing: nature of operation, likely pathogens, recommended, and alternative. So everyone should have this document, or this is kind of online free. So each and every almost yeah, available free. Only you have to kind of log in, kind of thing, free login. So whatever field you are working, so you should be knowing. But obviously this list is a very exhaustive list, and these drugs are according to their sensitivity or their national policy, Michigan state policy. So this cannot be directly copied in our setup. You have to take help of microbiology people. What is the probable organisms and what are the probable sensitivities? Then you can make your own. So mostly they have given these are very list, and dosing, they are very strict about dosing. We don't like in renal failure and what route to given, when to give an infusion. So these are very defined things. So ideally we should. So always harm versus benefit comes, and it is difficult to know each and every prophylaxis guidelines. So well informed in your field, get whatever guidelines, recent update of guidelines. I have seen this AHA has 8 times updated its guideline from 1999 to 1918. When to give, initially what was recommended now got outdated, and what was not recommended now that has come into practice. So recommendations, expert opinions, government regulations from many drug like antimalarial prophylaxis in endemic areas. Like in COVID, we took all prophylaxis. So policy documents, even government policy, especially for medical peoples, they will require to know government policy, when to give. So now everyone is getting this DEC prophylaxis for filariasis. So these things, even this prophylaxis things also comes from the government, may not be medically plausible, but you have to obey it, and always search for newer evidences or newer updates. So that will keep you well informed. So for surgical peoples, for surgeries, most of the surgeries, yes. For other non-surgical peoples, it is for means like 50% yes, 50% no, not all required. For medical peoples, you have to go through the like specific documents and you have to get it. So it cannot be concised in a single document or single book kind of thing. So hope I have finished it fast. So just I wanted to get an idea, because this topic was, I also first time read that, no, this is so much confused topic. So it was very difficult for especially compiling the medical data. Surgical, it is very clear. And for subacute bacterial endocarditis, it is very clear. Endoluminal procedures, very clear. Endovascular procedures, very clear. But for medicine, it is like, madam, you may have to keep a separate section for that. Thank you.